And we have 3 speakers, including myself, all from Canada, talking about a Canadian perspective this morning. The first speaker is going to be Frankie Bates, and our second speaker will be Grace Neustatter, and then I will speak third. I'm not going to do a lot of introduction because we're each going to talk about our clinic and give you a little bit of our own background as we get started. We do have simultaneous translation this morning to French. Unfortunately, there was no funding to do the French language slides, but we do have the simultaneous translation for any of you who prefer to listen in French. So without further ado, Frankie.
Bumping into each other here. Thank you very much, Kathleen. I'd like to thank the ICS Nursing Committee for inviting me here today. I have no disclosures to report. So my job here today is to discuss conservative, holistic approaches to treating urinary incontinence, something we as nurses in the room, most of us nurses in the room, know how to do best normally. So let's start with the definition of urinary incontinence. According to the ICS terminology, that urinary incontinence is a complaint of any involuntary loss of urine. Of course, that's the general term, and then we have sub-terminologies for stress incontinence, urge incontinence, mixed incontinence, and of course lower urinary tract symptoms. And urinary incontinence has always been hard to measure and define because it's not so much a quantitative problem, or how much your patients leak, but a qualitative problem, or how much it affects their quality of life. It's very difficult to measure and define. So we all know that urinary incontinence is a global problem, and according to the ICI, it's thought to affect approximately 400 million individuals worldwide. We know that's a grave underestimation of the true numbers, because most individuals, as we know in our healthcare practice, will suffer in silence. And we probably find in our practices, the same as the literature supports, it's about 2 to 5 years before individuals will come to seek medical attention from any healthcare provider. Now, if we were to assume that lower urinary tract symptoms remain stable for the next 10 years as they did the previous 10 years, it's thought that 2.3 billion individuals will suffer from lower urinary tract symptoms by the year 2018. That's 3 years' time. And Asia is thought to carry the highest burden with approximately 1.2 billion individuals, alarmingly high. When we look at the prevalence of urinary incontinence and compare it to other chronic common medical conditions, we actually see that urinary incontinence is actually more prevalent than both diabetes and ulcer, and as prevalent as chronic bronchitis, asthma, and almost hypercholesteremia. But unfortunately, we all know that it remains underreported, underdiagnosed, underrecognized, and still our patients end up going to their family doctor, getting the gumption to talk about their urinary leakage or fecal incontinence, and then being told, oh, it's just a normal consequence of aging, or a normal part of childbirth, and being dismissed. So we need to change that. So we know that assessment of our patients with urinary incontinence is vital. We need to extrapolate a very thorough history, and we know that can be subjective, but it's the only way we're going to find out what our patients need, what bothers them the most, and helps us to elicit the most likely diagnosis and treatment modality that will work for them, because it can't work for us. We need to conduct a physical exam, which also includes a vaginal or rectal or pelvic exam, a urinalysis or dipstick, and any positive findings to go for further investigations, especially if the patient is symptomatic. We need to conduct a post-void residual urine, and fortunately a lot of us in our practice have those lovely little bladder scanners now, so we don't have to do the more invasive procedure of clean intermittent catheterization for accurate measurement of our post-void residuals. We need to do a complete review of our patient's medication, both over-the-counter and prescription. We need to assess their functional ability. Have they got walkers or canes and it makes them difficult for them to get through the bathroom door? Perhaps they've got arthritis and find it difficult to sit on a lower toilet seat where they need a heightened toilet seat or a grab bar. And perhaps they're short of breath and just can't get to the toilet in a timely fashion. We need to look at past surgeries, especially in the pelvic area, like maybe our patients have had a TURP or a radical prostatectomy, hysterectomy, posterior anterior repair, or past bladder surgeries, which are going to be significant in your assessment. We need to rule out neurogenic causes that might affect that critical cortical pathway, that bladder to brain coordination, as I tell my patients. And we need to look at doing a 3 to 5 day bladder diary, padway tests. This is more valuable in a clinical trial setting, or using a validated questionnaire like the King's Health Questionnaire, and most recently, most of us are using in our practice the ICIQ, which is, they have the questionnaires now for both urinary and fecal incontinence, and the shortened version. So there's lots of support and evidence in the literature that show us that validated questionnaires and bladder diaries, like the ICIQ, are absolutely wonderful assessment tools that we should be using both at initial assessment of our patients and also to follow up to see if we had successful treatment outcomes for our patients. We need to look at identifying contributing factors to urinary incontinence. Again, like I mentioned, does that patient have mobility problems? Do they have reduced cognitive awareness, so they can't remember where the toilet is, or they can't recognize or remember what those bladder signals mean? Have they got constipation issues? We know that chronic straining against the pelvic floor will weaken it, and often that fecal loading in the lower rectum will compress against the bladder and reduce the bladder capacity. What's their fluid intake like, and is most of it caffeinated beverages that are irritating to the bladder? Have they got excessive weight, especially abdominally? And we have seen in the literature that urinary incontinence is 26% less likely if our patients are slimmer and more active. Are they smokers? The nicotine in cigarettes are irritating to the bladder, as well as our smoking patients will often have a chronic cough and again impact on the pelvic floor. Have they had previous pregnancies and difficult deliveries, which again impact on the pelvic floor? Do they have underlying medical conditions or medications that adversely affect the bladder? Have they got recurrent UTIs that might be causing a transient kind of incontinence? And are there environmental barriers to care? So many of our older patients have lots of clutter in their bedroom and they're trying to get up at night to go pee and trying to get across a cluttered room, and that's why we see so many higher incidents of falls in our older patients that suffer from incontinence. And we need to remember we can only change what the patient wants to change. This 100-year-old does not want to stop smoking, and if we don't listen to her, we're going to engage her in a smoking rehab that will help her to stop smoking. She doesn't want to. So remember, we can only change what they want, and we really need to recognize that we need to respect their dignity and humanity and listen to what they're asking for. So when we look at conservative treatments, and I don't believe this list is exhaustive, I'm going to go through each one of these treatment modalities individually, but I think it's important to remember that we should all be using standard clinical pathways of care. And this is, there's beautiful pathways documented in the ICI from 2013, and this will probably be looked at again in the ICI for 2016. So it's important we try to follow some standardized pathways. So when we look at behavior modification, when we're looking at conservative treatments, this should be one of the first line of interventions together with lifestyle changes. And there are different types of behavior modification, one being timed voiding. And you can do this for your patients that just keep ignoring the urge to void. They're at work, they're busy, nurses are known for this, holding their bladders all day and just not going until they're so busy. Put them on a timed voiding routine. Timed voiding is more often used when we put our patients on a scheduled timed voiding routine prior to their incontinent episode that we documented on their bladder diary. Bladder retraining is for those patients that go to the bathroom frequently and urgently, and when we do a bladder diary measurement, we see their bladder capacity is compromised. We teach them to ignore their first urge and go on their second urge, and increase the time intervals between ignoring the urge. Prompted voiding is for those cognitively impaired patients. We're going to prompt them and remind them, do you think your bladder's full? do you simply need to go to the bathroom and remind them where the toilet is and remind them that that strange feeling is actually a feeling of bladder fullness. And most of the time, this requires a lot of training, a lot of motivation from caregivers, whether they're at home or in long-term care facilities. So it's important to work with the caregivers as well as the patient. When we look at changing lifestyle factors, we need to ensure our patients have a good fluid intake. We say, generally speaking, as long as they don't have any concurrent medical disease with cardiac or kidney problems that are on a restricted fluid intake, about 2 litres a day, and try to minimize their alcohol and caffeine intake. And we have a coffee house in Canada, and you hear people saying, can I have an extra large double treble, please? And what that means is a coffee about the size of this one, and the double is cream doubled and treble is treble sugar. So you can manage how many irritants are in that one coffee that was documented on their bladder diary. So remember to get them to measure how many mils in their caffeinated beverages. And remind them that most of their fluid intake should be in the early hours of the day, into the afternoon, and not into the evening hours, especially if they're suffering from nocturia. We need to review the prescription medications, over-the-counter medications with them, see if they adversely affect the bladder, maintaining a healthy bladder, healthy weight, trying to get them into a cessation of smoking routine, and promote activity, active lifestyle, and help to prevent and treat constipation. So when we have a patient that from their 2-week bowel history looks like they're constipated, and typically I show the patient the Bristol stool chart, show them what a normal bowel movement looks like, because a lot of them think they're going every day, but they're little bunny balls, and they don't realize that's a constipated stool. So you need to educate your patient that a normal stool is soft, sausage-like, easy to pass, and it doesn't necessarily have to be every day. And so when you get that bowel diary back, you need to kind of determine, is it a slow transit problem or a motility problem in the bowel, which needs certainly more direction from a specialist and maybe radiographic imaging and more screening than we're going to manage at the nursing level, or is it a simple defecation disorder that we can look at the nursing level? If it is, we need to see what's contributing to that patient's constipation. Are they taking enough fluids? Have they got enough fiber in their diet? A lot of our older patients are using a lot of laxatives. Are they ignoring the urge to go? We see this all the time. Patients don't want to defecate in public because, oh, it smells, and there's lovely products on the market now that stop that smell. Have they got a sedentary lifestyle? Have they got a lot of drugs that are contributing to their constipation? And just lack of awareness. And like I say, I do show my patients a Bristol chart, show what's normal, encourage them to have an excellent diet of fruit, vegetables, whole grain breads, whole grain cereals, and tell them what's normal. How much fiber should a woman have? Well, about 25 grams a day for a female, about 38 grams a day for a male, and it's always good for them to look at the labels on their foods to see how much fiber they're getting. Again, track their bowel movements for 2 weeks for both consistency and frequency. So let's move on to pelvic floor exercises, and of course these really have been around since Methuselahism, but forever, for thousands of years, but really we didn't take notice or recognize them until the randomized controlled trials were done about 60 years ago by Dr. Arnold Tibial. Since then, we've seen wonderful quality randomized controlled trials, grade A level, and excellent studies done that show that pelvic floor exercises indeed do improve urinary incontinence more than no treatment at all. However, there are some fundamentals, certain fundamentals that need to happen or occur in order for pelvic floor exercises to be successful. One, of course, is that they need to isolate their pelvic floor. If they can't find it, then it won't get strong. And typically we need to do a pelvic exam to ensure that they have isolated the pelvic floor, measure the strength of that contraction, the endurance of that contraction, or how long they can hold it, and make sure they're not using any accessory muscles that they shouldn't be at that time. They need to be put on a daily exercise program, especially initially, and then onto a maintenance program. And there really is no standardization of how many repetitions, how many exercises, how often our patients should be doing that. So we all really need to work together and decide what do we teach our patients, what's best. But generally speaking, we teach our exercise program to squeeze their pelvic floor for 10 seconds or gradually get up to 10 seconds, and always rest that pelvic floor for the same period of time, because the rest period is just as important as the contraction period. And typically to do 3 sets of 10, 2 to 3 times a day. We need to teach them how to squeeze their muscle to exercise their slow twitch fibers of the pelvic floor, which helps with endurance and strength, and also how to exercise their fast twitch fibers, which helps recruitment of the pelvic floor in a quick fashion when our patients need to squeeze before they sneeze. We need to teach them what we call in North America appropriate use, and in Europe you call it the knack. Squeezing your pelvic floor, cough, 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 letting your pelvic floor go. So in that way we're squeezing the pelvic floor against the external sphincter and stopping that urinary incontinence from occurring. We as nurses need to supervise our patients and motivate our patients to keep doing them, and they will see benefit and results. Not overnight, because their pelvic floor wasn't wrecked overnight. And we also need to review core exercises or abdominal strengthening into their daily routine. And this will help with co-activation of the transversus abdominis muscle as necessary. Typically, I make sure my patients can contract their pelvic floor and isolate it before I start doing core strengthening, so they don't mix one up with the other. So there are 4 principles or requirements for pelvic floor muscles exercises to work. Specificity, they need to find it. Overload, they need to work their pelvic floor to the point of being tired, but not to the point of being exhausted. Progression, they need to move on. And maintenance, they need to long-term keep on a maintenance program. And this will all help to increase the cross-sectional area of the pelvic floor muscle and maximize their pelvic floor contraction. So pelvic floor muscle exercises, as I mentioned, clinical trials have shown they're more effective than no treatment at all. That high-load intensity training is more effective. Biofeedback's no more effective than pelvic floor muscle exercises alone, although it does have its place. And stimulation therapy can improve pelvic floor strength and tone, although there's limited evidence with this. So biofeedback is a technique by which patients receive a visual, auditory, or sensory information in relation to a particular body function, in this case, the pelvic floor. And stimulation therapy improves the proprioception of the location of the pelvic floor, so it helps the patient to isolate it and maximize their contraction. But we certainly need more high-quality studies to quantify this. This is the biofeedback and stimulation therapy equipment. And as you can see, larger vaginal probes, smaller rectal probes, ones with the metal bands send stimulation to the ventral nerve and afford reflex contraction of the pelvic floor. The rubber ones are for the biofeedback therapy. And studies have shown that 30% of females and 20% of males cannot contract their pelvic floor muscle at their first consultation. So this is a great treatment to help isolate and find that pelvic floor. Posterior tibial nerve stimulation can come in the form of either sacral neuromodulation, which would be more for the surgeons. For the nursing level, percutaneous or transcutaneous tibial nerve stimulation is a great way to treat either overactive bladder, urgency, nocturia, interstitial cystitis. And we bring the patients in for 8 to 12 weeks, which is in line with the literature, and they eventually buy their own device, go home, and treat themselves. And they learn how to find the tibial nerve, which is most proximal to the area, by measuring 1, 2, or 3 finger breadths above the ankle bone. It works extremely well. Lots of evidence to support both percutaneous and transcutaneous tibial nerve stimulation for overactive bladder. And of course, various products on the market. Pads have their place. You might have a patient that all she wants is a product to get her to bingo once a week. Penile clamps definitely have their place for our men that are soaking wet, that find that they leak through their products. Clean intermittent catheterization for our neurogenic bladders with overflowing continence. And pessaries, and there are some wonderful pessaries now that are even self-fitting and made from a high-grade medical silicone, so very comfortable for our patients, that helps to kind of stabilize the urethra and provide support to prevent stress incontinence. So wonderful products on the market. So in ending, just make sure your patients feel, you know, that they're not isolated and alone. This was a true depiction of Hurricane Ike in Florida, and this house is the last house standing, and oftentimes that's how our patients feel. So I'd like to welcome your questions or comments.
Is this working? You mentioned the need to work from the point of the patient themselves in terms of what they want. And our experience is that often people have very low expectations, isn't it? That they come expecting that we're going to give them pads. So there's a negotiation around that, and I just wondered if you'd like to comment on that.
So, like a lot of the patients, I don't think they understand the role of a nurse specialist in treating urinary incontinence. They think it's just a general part of aging, and that the only option is to get a pad to contain. So I think it's important to explain to them and teach them, you know, there are treatment options, there are conservative treatment options. You don't have to have a surgery. There's not just the option of a pad or a containment product. There's lots of other viable options. And by speaking through them, then they can decide for themselves, and giving them choices, telling them that how would you like to be treated, listening to their problems, listening to when their incontinence bothers them really helps, and trying to put them in control and self-motivate them to want to be dry and want this treatment, not what treatment I want for you, what treatment you want. Does that answer your question?
It does. And I guess I'm reflecting on being a community nurse, and when you're a community nurse, you're definitely not in a power situation. You're going into somebody's home, so ultimately you have to abide by what they want, and there's a fair bit of education and negotiation. So thank you.
Thank you.
Donna Bliss from the US. Thank you, Frankie. That was a fantastic overview. I wonder if you might comment on your approach in working with maybe some elderly but community living individuals who might come with a caregiver. Are you seeing that increasing in your practice, where it's not just, say, a younger, perhaps woman coming, but maybe her daughter's coming with her, and that negotiation or strategies between the two of them?
Yes, and it's very difficult because you have to ask the patient first, is it okay that your daughter or your husband come to your consultation with you? And if they're in agreement, ask them, how much do you want to be involved? How much do you want your husband or caregiver to be involved? So I think it has to be the patient's choice. And even more difficult if that patient's cognitively impaired, because sometimes they don't even realize it at the point you have first contact, and they think their husband or wife's crazy saying that. And so that makes it even more difficult. But I think still it's important to listen to your patient first, see what they want, and if they don't want the caregiver included, which often we need with the cognitively impaired, then we have to respect their wishes. Thank you.